Hi, I'm Dr. Peterson, one of the EMS physicians here with Regions EMS. I'm here with Jennifer Shea, our education supervisor, and we're going to talk through some questions for the medical directors that have come up through some recent CME sessions. This is something that I think we're going to be doing on a regular basis going forward. We just seem to get the same questions that come up repeatedly at CME sessions. So all of you guys are thinking the same things, you're asking the same questions, and we want to make sure that we're addressing those and everybody's getting the same information from this.
Great, thank you.
Let's get started.
We have recently switched to using the 30 and 2 setting on the Lucas in cardiac arrest. My understanding is that this has to do with efficient ventilation when using the I-gel. Where could a provider go if they wanted more information?
Yeah, this was a recent change with the ACLS recommendations in the last few years. Once you have an endotracheal tube, it really doesn't matter. You can do the continuous, but before you have that, we're still seeing that we've learned some of this from the ECMO project too, where patients that have an I-gel in place that have been receiving continuous compressions with the intermittent ventilations are coming in with very poor oxygenation in their blood on some of the blood gas values that we've been seeing from the ECMO patients compared to the patients who have received an endotracheal tube. And so one theory is that the I-gel is just seated against the larynx. So if you're compressing the chest and basically you're compressing the lungs, probably much more so than you're compressing the heart, there's a good possibility that it's every time you do a compression, it's unseating that I-gel, and you're just not getting the same ventilation, especially if you happen to give a breath when that happens, you're not going to get any of that air into the lungs. Versus when we have the endotracheal tube with the cuff that's in the trachea and the rescue pod that's preventing anything from happening to the lungs unless we allow it to happen. So you can give a breath during a compression because you just have to overcome that compression pressure and there's nowhere else for the air to go. But with the I-gel, if you're giving a compression and a breath at the same time, what's most likely happening is you're just blowing that I-gel away from the larynx and the patient's not getting any of that air. It's still something that we're learning about, but until you have an endotracheal tube with a cuff in place, you really should be using the 30-2 compression ventilation ratio setting on the Lucas, and especially if you're doing manual CPR, that's the recommendation for 2 rescuer CPR for adults.
That makes sense. Thank you. What is the proper action if our patient does not want to be transported to the appropriate hospital? For example, they should go to the trauma center, but they know the staff there.
Yeah, that's tricky. So ultimately, this comes down to some ethics of medicine. So the 3 main things are patient autonomy trumps everything else. Mm-hmm. That means that patients have the right to refuse treatment, to make requests, and we should really honor that unless there's reason to believe the patient doesn't understand what decision they're making. The other thing is do no harm, and then also justice. We want to do the most good for the most people and make sure that the care we're providing is fair and equitable. So this falls under the patient autonomy, which is one of the more important aspects of medical ethics. And we really need to honor the patient's wishes unless they are completely confused, obtunded, making an irrational decision for whatever reason. And that's a clinical judgment. I can't make that black and white and tell you if this, do this, if that, do that. You need to decide if the patient in front of you seems to understand what they're deciding and if it's a reasonable, rational decision. So yeah, absolutely, I could see, man, I don't want to go to Regions Hospital. I work there. They're going to cut all my clothes off. I know all the ER nurses and docs. That's embarrassing. If I'm hemorrhaging out, I'm hypotensive, I'm in shock, maybe that still is going to be the right thing for me, and that's just something that you really need to push on the patient, because where else are you going to go? The next closest would be most likely Hennepin County, and that's a good 20 minutes down the road at least, 20 to 30 minutes. So what I would suggest in that situation is you really try to understand why the patient is making that request. And if it's because they might be embarrassed, let's weigh that against what we know about their current clinical status. Are their vitals stable? Do they have any obvious injuries that are apparent to you that you're concerned they might deteriorate in the next 20 to 30 minutes. But if they really say, you know what, I just have a broken leg or broken ankle, motorcycle accident, my vitals are fine, I'm not confused, no evidence of a head injury, and I don't want to go to Regions because I just know too many people there. That's a reasonable request, and as long as you communicate to them that, hey, there is a risk that by going farther something could happen and you could get worse. Whereas if we go to Regions, that's closer, things will happen quicker. But if the patient understands that and still requests to go to another facility, that's fine. I think where I would maybe really step in is if rollover, they have bilateral open fractures or something like that, it would be a trauma team activation at Regions, and they're requesting to go to, let's say, St. John's or Woodwinds because they get their care there. That's a request where I would say, you know what, they do not have the resources there to care for you. You will end up at Regions. They will not be able to take care of you there. Just like taking a STEMI patient to Woodwinds or to Lakeview, where there is no cath lab available for those patients. That's where you can override it. But if they're requesting a different trauma center and the request seems reasonable, M Health, Fairview U of M is a level 2 trauma center. That would be appropriate. Hennepin County is level 1. We're far enough away from North Memorial that's really not going to come into play on the East Metro, and then Regions obviously. United and Lakeview are level 3 trauma centers, so some of the minor mechanism of injury stuff could go there, assuming the patient is otherwise stable. But in general, we do need to honor the patient's request if it's a reasonable request. But it's our duty to inform them of why we're concerned about honoring that request and why we feel they maybe should go to Regions. But as long as they can understand that and are processing information rationally, that's a reasonable request that we can honor.
That makes sense. That was good. When treating a pediatric overdose patient, would it be more appropriate to call MRCC or poison control first?
I think it depends. If the patient is unstable in any way, I would call MRCC and I would get moving towards Children's or Regions or the appropriate facility. It's situations where the kid gets into something and you're not sure. The kid looks fine. Maybe they vomited, maybe they haven't, but they're awake. They're not obtunded. Their vital signs are reasonable. Those are the cases where it is okay to call poison control directly. Poison control is an excellent resource, and they will not hesitate to tell you to take the kid to a hospital if they think that's the right thing to do. But there's certain things, even like rat poison. Rat poison is basically Coumadin, or a kid gets into a big bottle of ibuprofen and has a handful of pills. There's really, short of, we just don't pump out stomachs like maybe we used to 20, 30 years ago. So you're not going to get someone to the hospital just to have their stomach pumped. There's activated charcoal and there's some other things we can do, but it's not always necessary. Rat poison is basically warfarin. So it creates a bleeding risk several days down the road, but there's really not much to do in the meantime, and poison control might be able to say, hey, the kid just needs to take some vitamin K supplements for a few days. And I'm just making this up. This isn't a real case. This isn't anything that, take my medical advice or anything like that. I'm just coming up with this off the top of my head. So if the kid is unstable and clearly in distress, they need to go to the hospital right away. So then there's you could definitely call poison control, but don't let that delay your transport because they need to get to the ER. If it's something that's less critical and you're just worried, what do we need to worry about here? What should we watch for? Certain plants, animal bites, spider bites, and obviously medications would be the main thing, or chemicals. You can definitely call poison control if the kid looks stable, and they'll give you some really good guidance from there. You can also then take that information to call MRCC to speak to a doc if you're going to do a no-load, and say, hey, we spoke with poison control, here's the advice they gave us, does that sound reasonable to you? And then that makes our job a little bit easier to sign off on that too. Poison control is staffed generally with pharmacists, and they really know their stuff, so it's a great resource to utilize.
Oh, that's interesting. Thank you very much for taking the time to answer our questions.
Absolutely.